Dear Chairman, esteemed colleagues, first of all, I would like to thank you for the invitation to the summit dedicated to HIFU treatment, and I hope that our meeting and the exchange of our experience will help us to achieve productive results in the era of HIFU treatment. The purpose of my presentation is to present the results of our work on the application of non-invasive remote tumor tissue ablation using high-intensity focused ultrasound and the Pirogov National Medical and Surgical Center, a multidisciplinary hospital offering all types of surgery, including HIFU ablation. This method was introduced in Russia in 2009. Compared to other local tumor ablation techniques, HIFU ablation employs a novel approach, non-invasive remote destruction of tumor tissue. We initiated work with this method in March 2009. Given this esteemed audience, there is no need to elaborate on the physical principle of HIFU. Instead, I will briefly demonstrate our clinical experience. The Pirogov Center team is a cohesive unit dedicated to mastering and applying cutting-edge treatments across all medical fields. Our department's team is shown on this slide. Our priority areas are the treatment of uterine fibroids, non-resectable pancreatic tumors, and benign malignant liver lesions. To date, we have performed over 1,300 procedures with gynecology, specifically HIFU ablation of uterine fibroids, being the primary focus. Initial scientific structural changes in treated fibroids are observed intraoperatively, characterized mainly by altered nodules, parenchymal density, and emergence of hyperechoic areas. This effect occurs in about 75% of cases. Such changes indicate necrosis development, later confirmed by MRI. Contrast-enhanced MRI series clearly depict a fibroid pre-HIFU ablation, post-ablation necrosis within the nodule, and subsequent volume reduction at 6 months, 1 year, and 2 years with persistent necrotic zones. HIFU causes destruction of both parenchymal and stromal tumor components. Light microscopy revealed extensive necrosis. Central peripheral areas showed arterial, venous, microvascular walls with hemorrhagic thrombi, occluding lumina. Body zones with intact myometrium exhibited mild lymphocytic, predominant inflammatory infiltration. 3 primary MRI types based on T2-weighted signal intensity relative to myometrium skeletal muscle. Type 1, predominant low T2 signal, black nodules, histology simple fibroid without stromal edema. Type 2, predominant intermediate T2 signal, gray nodules, histology proliferative fibroid without edema, minimal connective tissue, OR, simple fibroid with diffuse stromal edema. Type 3, predominant high T2 signal, white nodules, histology proliferative fibroids with significant diffuse stromal edema. Our study included 133 patients with 236 fibroids. Largest group, nodules about 100 centimeters cubic, linear dimension about 6 centimeters. Larger fibroids responded less effectively to HIFU. MRI confirmed all such nodules were type 3. 31 of 49 women planning pregnancy successfully conceived, delivered post-HIFU. Treatment failure. Example, pre-HIFU ultrasound, 50% reduction at 6 months, regrowth at 12 months. Nodule structure showed a large venous vessel. Patient underwent embolization of fibroid feeding vessels. Nodule volume decreased 1 month post-embolization. Combined therapy clinical trial. Patient, non-pregnancy seeking, fibroid about 9 centimeters. Protocol. Stage 1, selective embolization of fibroid feeding arteries. Stage 2, HIFU ablation. Trial cohort, 105 patients treated. Average 2 nodules per patient, about 9 centimeters. 1 month outcomes. Table compare volume reduction, combined therapy, embolization plus HIFU, control group, HIFU alone. Significant difference observed at 1 month. 6 months outcomes. Nodule reduction, combined therapy 62%, control about 50%. 12 months outcomes. Nodule reduction, combined therapy 76.5%, control less than 65%. Since 2016, SonarView used for intraoperative HIFU monitoring. Slide show pre-ablation contrast scan, intraoperative cavitation signs, post-ablation non-enhanced necrotic zone. Contrast use reduced procedure time by several hours. HIFU complication. Most common, the first or the second degree skin burns. Conclusion. HIFU ablation is non-invasive, safe, synergistic with organ-preserving techniques, e.g. embolization. Avoid surgery and shortens pre-pregnancy interval in select cases. Thank you for your attention.
Thank you, Dr. Ekaterina, for sharing your great experience at your center in the Russian Federation. It certainly demonstrates the great unsuccessfulness of HIFU technology. Thank you, Doctor.